Welcome to your monthly update on progress with the COVIDENCE UK study. My name's Adrian Martineau. I'm the lead investigator based at Queen Mary University of London. I'm pleased to say that enrolment has proceeded well in the several months since we started on the 1st of May 2020. We now have hit our target of 12,000 people signed up to the study, which is a fantastic achievement. Thank you, everyone. Another fantastic achievement is the very, very high rate of completion of monthly questionnaires. No fewer than 94% of you have completed the monthly questionnaires we send you. And this really improves the value of the study and ensures that the data you're giving to us have maximum value. I'm going to share with you the results of our latest analysis of data from the first 10,000 people to sign up, looking at risk factors for COVID-19 in the following categories. First of all, let's look at the effect of age on risk of COVID-19, as defined by the symptom complex of dry cough, fever, and lack of or loss of sense of smell and taste. What you can see here is that the percentage of people who've had probable COVID-19 based on these symptoms is highest in the 40 to 49 age group and declines with increasing age to a low of around 5% in those aged 80 plus. This finding contrasts with those of hospital-based studies, of course, showing that higher age is associated with increased severity of disease. Hospital-based studies also show that men tend to have a worse outcome from COVID-19 than women. But interestingly, findings from our population-based study show no statistically significant difference in risk between men and women for probable COVID-19. In terms of ethnic differences in risk, what we do see is an increased risk of COVID-19 symptoms in people of Black or Asian ethnic minority origin who are born in the UK. It's a slightly increased risk in those of Black or Asian minority ethnic origin born outside the UK, and the lowest risk is from white British people born within the UK. Lower household income is associated with increased risk of probable COVID-19, with those with the highest or those in whom household income is sufficient for basic needs having a 9.3% risk of COVID-19 compared to a risk of between 16 and 20% for those in the other categories. No association was seen for housing type or educational level. We saw a higher risk of COVID-19 symptoms in those who have frontline jobs, such as working in healthcare, public transport and shops. However, we saw no association with shielding, household overcrowding, use of face masks or gloves in public, use of public transport or frequency of visits to the shops. In terms of underlying health conditions, our question on general health revealed an increased risk of symptoms among those who had good, fair or poor general health. We also saw a slightly increased risk in people who are overweight compared to those who are not. However, and importantly, no association was seen for people with diabetes, heart disease, high blood pressure, asthma, chronic bronchitis, emphysema, kidney disease or cancer when compared to people who didn't have these conditions. Again, this contrasts with hospital data, which indicate that people with these conditions may have more severe disease. What our data from the population level show is that people with these conditions aren't necessarily at increased risk of getting COVID-19 in the first place. In terms of medications, we've now classified over 20,000 of your medications into 19 different categories, and I'm pleased to say that none of these showed an association with increased risk of disease. Neither did a lack of a vaccine with BCG or the MMR vaccine. Similarly, we saw no associations between the type of diet that people have and their risk of COVID-19. In particular, there was no association either way that was seen for vegetarianism or veganism. In terms of lifestyle factors, it was interesting to note that people who take 1 or more hours of vigorous physical activity per week tended to have a slightly lower risk of COVID-19 than those who didn't. But we're unable to say whether this is cause or effect due to the cross-sectional nature of the study. We saw no effect of smoking, vaping, alcohol consumption, less vigorous exercise such as walking or yoga, or the number of hours of sleep that people are reporting they get each night. To summarise then, the take-home messages from the findings so far are that over 12,000 people have now been recruited to the study with excellent follow-up rates of 94%. We've shown that many of the risk factors for COVID-19 in the community that I've discussed today are different to those reported in hospitalised patients, and this underlines the complementary nature of the information provided by a population-based study like COVIDENCE UK compared to case control studies done in patients who are ill enough to require hospitalisation. A reassuring finding from COVIDENCE UK is that neither underlying conditions nor any medication was associated with increased risk of COVID-19. There are no grounds to change your regular prescribed medication in an effort to reduce your risk of COVID-19, as we found no evidence that they're associated with increased risk. An intriguing finding was that lack of exercise associated with increased risk of COVID-19, but with the current cross-sectional design, we're unable to say whether this is a cause or an effect. To work this out, we need to continue to collect follow-up data over the months to come, and this will provide insights which will allow us to answer this question definitively. So I would urge you to please continue to fill the monthly questionnaires as you have been, and if you get symptoms of COVID-19, such as a fever, a dry persistent cough, or loss of sense of smell or taste, please apply to get a free NHS test, which can be requested either online at nhs.uk coronavirus or by calling 119. So from all of us at COVIDENCE UK to all of you, thank you for your participation. Goodbye.